Good afternoon, and welcome to our second ACCP AST Resident Research Webinar of 2026, supported by our ACCP Transplant PRN and AST Transplant COP. My name is Crystal Vo, and I am a PGY1 resident at Mayo Clinic, Arizona, and it is my pleasure to moderate today's webinar alongside with Samantha Shirk, also a PGY1 resident at Mayo Clinic, Arizona. We are honored to have our resident research today. Friendly reminder, this is one of 3 webinars and all are available for CE credit. And an email will be sent out to attendees at the end of the webinar to obtain CE from Rush University. Before we get started, here are a few quick notes before we begin. For our audience members, please ensure that your microphone remains muted for the duration of today's presentation. Just a reminder, the mute button is located in the lower left-hand corner of your screen. If at any point during the presentation you have a question for the speaker, please go ahead and use the chat function at the bottom of your screen and send your questions to me directly to minimize any possible interruption. We will take questions at the completion of the presentation. Today's webinar will also be recorded and posted on the official ACCP Transplant PRN YouTube channel. At any time, if you do experience any technical difficulties during this webinar that is not fixed by logging out and refreshing your internet connection, just go ahead and message either Samantha and I, and we'll try to help out. Without further ado, I will turn it over to Samantha to begin our webinar.
Thank you, Crystal, and thank you everyone for coming today. We will get started, and today's presentations will focus primarily on the contemporary approaches to immunosuppression in kidney transplantation. For this webinar, our objectives are to evaluate the emerging research findings from pharmacy resident projects in solid organ transplantation and their implications for contemporary clinical practice. We will also be assessing immunosuppression strategies in kidney transplantation, including effects of allograft outcomes, adverse events, and infectious complications. And lastly, we will identify opportunities to optimize transplant center practices based on presented data, including areas for future research. All individuals in control of this content do not have any financial relationships to disclose, and these presentations may include discussion of off-label medication use. I do have a little QR code here for you. It is the Joint AST and ACCP Research Committee has created this research toolkit, which is available to members in the AST COP Hub and on the ACCP TXP PRN websites. You can check it out for helpful tips on regulatory information, data management, and survey-based research. But without further ado, we will get started, and I'll hand it over to Sam Henschel, which is a PGY2 solid organ transplant at Rush University System for Health.
Hi everyone, my name is Samantha Heinchel. I'm the current PGY2 solid organ transplant pharmacy resident at Rush, and my research will be presented today on the evaluation of anti-thymocyte globulin, or ATG as I'll refer to it throughout this presentation, as induction immunosuppression in older adult kidney transplant recipients. Sorry, I'm trying to advance to the next. Oh, there we go. Okay. I have no conflicts of interest to disclose today. And to give some background information, ATG is a commonly used induction agent for kidney transplant recipients, especially those that are at high immunologic risk, such as those highly sensitized prior to transplant. ATG works by inducing immediate immune cell depletion, working on both T and B cells. A study published in Transplant Proceedings by Laftavi and colleagues compared low-dose ATG at 3 mg per kg in kidney transplant recipients over 65 years of age to those less than 65 years old. The study observed similar patient survival, post-transplant length of stay, and safety outcomes between groups. All right. In 2016, Rush made the decision to change our induction immunosuppression protocol for kidney transplant recipients, including a lower dose of ATG for patients that were 65 years and older. We use an ideal body weight to dose ATG at our institution, and the new protocol indicates 5 mg per kg total for those less than 65 years of age and 3 mg per kg total for those 65 years or older. This protocol change raises the question about the effect this had, if any, on our overall rejection rates. And this study aimed to evaluate the rates of rejection in the population receiving lower dose of induction ATG, as well as predefined safety outcomes. So patients included in this study were all 65 to 70 years old at the time of their transplant. Specifically, the low-dose ATG group included kidney transplant recipients between January 1st, 2021 and July 31st, 2024 that received ATG 3 milligrams per kilogram total as their induction agent. The standard dose ATG group included kidney transplant recipients between November 1st, 2012 and September 30th, 2018 that received ATG 5 milligrams per kilogram total as their induction. You'll notice that there is a timeline gap in the data that was collected. We chose to start collecting the low-dose ATG group in 2021, despite the protocol being changed in 2018, as I mentioned, due to the COVID-19 pandemic and the high incidence of off-protocol decisions made during that unprecedented time. I also want to point out that the low-dose ATG group is the data that I collected as a comparator to a previously collected data set for the standard ATG group. Due to a previous resident at Rush having collected this standard dose data, you'll notice there are some gaps in the data throughout this presentation, as we were at the mercy of the data that was available to us at that time. Those excluded from this study were any patients with a previous transplant due to high immunologic risk confounding the protocolized induction regimen, and any patients that received a multi-organ transplant. So the primary endpoint evaluated in this study was biopsy-proven rejection at 6 months and at 1 year post-transplant. And additional secondary endpoints included patient death at 1 and 3 years post-transplant, as well as graft loss defined as permanent dialysis and at 1 and 3 years post-transplant. Demographics and pre- and post-transplant patient data were collected from our EMR and from UNOS, and they were managed within REDCap. SPSS was used to perform statistical analyses with Fisher's exact test used as appropriate, and a p-value of 0.05 as the threshold for statistical significance. So baseline characteristics for both groups are seen in this table, and I specifically want to point out the data highlighted in red there at the bottom. A majority of the patients were on dialysis prior to transplant in the low-dose ATG group, though the information was not available for the standard dose group, indicated by NA there. Deceased donors were also the most common donor type in both groups, which I think is important to point out given that living donor kidney transplant recipients have an inherently lower risk of rejection due to many things, but also including lower ischemic times. More baseline characteristics for both groups are seen here, and I want to point out that the most common etiologies of end-stage renal disease were diabetes and hypertension for both study groups listed. So now looking at the primary outcomes, of the 66 patients that were included in the low-dose ATG group, 3 patients, or 40.5% of patients, experienced biopsy-proven rejection at 1 year post-transplant. Of the 16 patients that were included in the standard dose ATG group, 2 patients, or 12.5%, experienced biopsy-proven rejection at 1 year post-transplant. I want to point out that the low number of patients included in the standard dose group is likely due to the fact that alemtuzumab was still being utilized for induction at RUMC throughout the time period that this data was collected. Those patients were not included for the purposes of this presentation. So the absolute risk difference, or RD, indicates that patients in the low-dose ATG group had 8.0% lower absolute incidence of rejection. Risk reduction, or RR, illustrates that patients in the low-dose ATG group experienced an estimated 64% lower relative risk of rejection compared to the standard dose ATG group with a 95% confidence interval of 0.07 to 1.96. The confidence interval does cross 1.0, which indicates insufficient evidence to conclude a statistically significant difference in rejection risk. Approximate two-sided Fisher's exact p-value of p equals 0.24 indicates the difference in rejection between groups was not statistically significant at the conventional 0.05 threshold. So the type of rejection and treatment associated with each rejection episode is shown in the table here. Acute cellular rejection was the most common type experienced in both groups, with the most common treatment being high-dose steroid pulse in the low-dose thymo group and a mix of ATG, IVIG, and plasmapheresis as treatment for the rejection occurring in the standard dose group. I thought it was also important to include the immunosuppression regimen for each rejection patient at the time of the rejection episode. All patients were on prednisone 5 milligrams daily, but 0 patients were on our standard full dose mycophenolate 1000 milligrams BID per protocol at Rush, and 1 patient had an average undetectable FK level within the month prior to rejection. The information provided in this table is only included for the low dose ATG group, as the data was not available for the standard dose group. Finally, safety outcomes analyzed in this study are provided in this table here. I want to point out that around a quarter of patients in both ATG groups experienced BK viremia post-transplant. There were also a significant amount of patients that experienced positive urine cultures in both groups, with over half being treated as a UTI with antibiotics in the low-dose ATG group. These infection outcomes may not necessarily be a reflection of the induction regimen they received, but a reflection of the maintenance immunosuppression causing infection-related complications post-transplant. So the results of this study suggest that the transition to low-dose ATG induction in older kidney transplant recipients at Rush did not increase rates of rejection. Despite this, however, findings should be interpreted cautiously, as the study may have been underpowered due to limited sample size or low event rates. This is likely related to what I explained before, the use of alemtuzumab as induction in a majority of patients throughout the time period that was collected in the standard dose ATG group. Larger studies may be beneficial to determine if further decrease of dose of ATG induction in this population may improve rates of bacterial and viral infections, as well as the impact maintenance immunosuppression regimens on both rejection and safety outcomes. So that's all I have for you today. Thank you so much for listening, and I'll now open the floor to any questions that you guys have in the audience.
Hi, we did have one question from the audience. The question is, since ideal body weight was used for dosing, did you evaluate whether outcomes differed between patients with normal versus elevated BMIs?
No, but I do think that makes a great point, seeing as you would receive more or less depending on what your BMI is in relation to your ideal body weight. I think it helps that we standardize ideal body weight for everyone, so that we are using the same marker or measurement for their body weight. But I do think that would be an interesting thing to evaluate going forward for future research.
Thank you.
Does anybody have final questions for Samantha?
There was also another question in the chat. In your baseline demographics, did you collect PRA or CPRA between groups?
Yeah, we did collect PRA between groups. However, it wasn't available for all patients. So unfortunately for specifically the low dose group that I collected, I didn't think it was necessarily relevant to include because it wasn't information we had for all 66 included patients. But I think maybe in the future when presenting on a larger scale or with more time allotted, it could be interesting to go through that data as well.
Perfect. Thank you, Samantha. We will next be hearing from Jessica Mamali, which is a PGY1 pharmacy resident at the University of Illinois Chicago Gretzky College of Pharmacy. I am not sure I can hear you on our end.
Okay, are you guys able to hear me now?
Yep, we can hear you.
Okay, sorry about that. Um, well, hello everyone. Like she said, I'm Jessica Mamalio. I'm a PGY1 acute care resident at the University of Illinois Chicago, or UI Health. And today I'll be presenting on my research project, the effects of mycophenolate load on leukopenia in obese versus non-obese kidney transplant recipients. I'd like to thank my co-investigators, Dr. Maya Campara and Dr. Dana Pierce. And none of us have any relevant financial conflicts of interest to disclose. So a little bit of background on the solid organ transplant program at UI Health. We are a center that only does abdominal transplants, and we are also the center that performs the highest number of kidney transplants nationally for patients with a BMI greater than 40. This is significant because transplant centers often decline patients who have a BMI greater than 35 due to their increased risk of surgical complications. So we have the unique opportunity to manage this high-risk population. UI Health is also part of the minority of centers that are steroid sparing to reduce morbidity and mortality associated with cardiovascular disease. But because steroid sparing centers are in the minority, there's limited data to guide immunosuppression management in this transplant population. So here's the mycophenolate loading regimen we use at UI Health. You can see that the load is done in conjunction with the prednisone taper. And not only is UI Health one of the only transplant centers that does a mycophenolate load at all, out of the centers that do, we have one of the most aggressive dosing strategies. And originally, this load was completed in all patients, but in June 2025, our protocol was updated to only complete this load in patients with a BMI greater than 30. This is because clinicians were concerned that non-obese patients were experiencing exposure-related adverse events. And not only are we increasing mycophenolate exposure with this loading regimen, but there's data to suggest that BMI and weight also affect exposure. Some of the studies support our concerns. For example, the study by Kaplan and colleagues found that patients who are at lower extremes of weight may have increased mycophenolate exposure. The study by Chen and colleagues found that patients with a lower BMI may be at higher risk for leukopenia. And the study by Kuipers and colleagues found that increased mycophenolate exposure may increase the risk of leukopenia. So based on the current literature and our observational experience, we initially sought to determine whether or not non-obese patients experienced higher mycophenolate exposure after loading doses compared to obese patients. But given that therapeutic drug monitoring for mycophenolate isn't routine, we shifted our focus to something that we could more clinically measure, which is whether or not non-obese patients are at greater risk for leukopenia. So our study objective was to compare the incidence of leukopenia within 6 months post-transplant in obese versus non-obese kidney transplant recipients who have received a load of mycophenolate. Our hypothesis is that patients who are obese will have a lower incidence of leukopenia within 6 months post-transplant. This was a single-center retrospective cohort study of adult kidney transplant recipients who were transplanted between August 1st, 2022 and August 1st, 2024 with at least 12 months of follow-up. However, to capture 12-month mortality, patients with less than 12 months of follow-up were included if death occurred within that period. Our primary outcome was the incidence of any leukopenia, defined as a white blood cell count less than 4,000 within 6 months post-transplant. Secondary outcomes included the key one-year outcomes seen in many kidney transplant studies, including acute rejection, defined as biopsy-proven or empiric treatment, graft function based on eGFR, graft survival, and patient survival. We also wanted to capture letermovir use for CMV prophylaxis as a secondary outcome. For our safety outcomes, we wanted to look at the incidence of other cytopenias, including neutropenia, defined as an ANC less than 1,500, and anemia defined by the KDIGO criteria. Also looking at the incidence of rescue medications for these cytopenias like GCSFs and ESAs. And lastly, we wanted to look at the incidence of infections, focusing on CMV, adenovirus, and parvovirus because they can also cause cytopenias. Infection was confirmed by PCR and included patients that had a positive PCR that was below the lower limit of quantification. Now here is a comprehensive list of my inclusion and exclusion criteria, but focusing on the more pertinent criteria, starting with the inclusion criteria. We wanted to include patients who used thymoglobulin as the only induction agent, those who received a full mycophenolate load based on total dose, which was defined as 9,360 milligrams of mycophenolate sodium or 13,000 milligrams of mycophenolate mofetil. And lastly, we wanted to include only patients who were discharged on valganciclovir for CMV prophylaxis. And this is because for patients that aren't discharged on valganciclovir, who are discharged on acyclovir, we recognize that acyclovir can also cause cytopenias, but per our protocol, patients on acyclovir are only continued for 1 month versus 6 months on valganciclovir. And we were worried that this difference in exposure may result in different rates of leukopenia. And now moving on to our exclusion criteria, we wanted to exclude patients on agents other than tacrolimus and mycophenolate from maintenance immunosuppression. We wanted to exclude patients who were on steroids for immunosuppression past post-op day 5. And this is because while patients can be continued on steroids on a case-by-case basis, we wanted to collect data for our steroid-sparing patients, again, due to the lack of data in this population. And lastly, we wanted to exclude patients on cyclosporin at any time during follow-up due to the interaction with mycophenolate. For our statistics, we calculated that a sample size of 106 was to provide an 80% power to detect an absolute effect size of 16.9 percentage points between groups using a two-sided alpha of 0.05, and this was based on the Chen and colleagues study that I mentioned earlier. Now, looking at the patients we assessed for the study, we were able to assess 362 patients, but had to exclude 276, primarily because they didn't receive the full mycophenolate load. 86 patients were included in the study, with 41 in the non-obese group and 45 in the obese group. Looking at the baseline characteristics, you can see that they were generally well matched. However, looking at the etiology of kidney failure, you can see that more patients in the obese group had diabetes as an underlying etiology compared to the obese group, and this difference was statistically significant. However, this isn't very surprising considering diabetes and obesity are closely linked comorbid conditions. Also, you can see that the eGFR in the obese group was lower compared to the non-obese group, and this was also statistically significant. But it's important to note that eGFR is often underestimated in obese patients because the CKD-EPI equation standardizes eGFR to a BSA of 1.73 meters squared, and obese patients have a higher BSA. Also, we are currently in the process of analyzing KDPI and DGF data, which may give us more insight into this difference. For our primary outcome results, you can see that there was no statistically significant difference in the rate of leukopenia between groups, with rates of 98% in the non-obese cohort and 91% in the obese cohort, the p-value of 0.36. For our secondary outcomes, there was also no statistically significant difference between the one-year outcomes for graft function, acute rejection, graft loss, and patient survival. and also no difference in conversion to letermovir. For our safety outcomes, there was no statistically significant differences in the incidences of neutropenia, anemia, rescue medication use, adenovirus, and parvovirus infections. For anemia, I did want to highlight that 100% of patients in both groups did experience anemia. And then you can see here that the BMI greater than 30 group or our obese cohort has a statistically significant higher rate of CMV viremia at 6 months. We are currently in the process of analyzing CMV risk at the time of transplant. Again, also analyzing KDPI and DGF data, which may give us more insight into this difference as well. So in conclusion, when looking at leukopenia as a surrogate marker for safety, the mycophenolate load may be safe in obese and non-obese kidney transplant recipients. Our other safety outcomes for the most part also support this, again, pending additional data on CMV risk, KDPI, and DGF. When looking at efficacy, you can see that the mycophenolate load may not be associated with a difference in efficacy in obese versus non-obese patients. With regards to limitation, our main one here is that we didn't have therapeutic drug monitoring for mycophenolate, thus we couldn't make a definitive correlation between exposure and incidence of leukopenia. And as I've mentioned, we are currently in the process of collecting DGF, KDPI, and CMV risk at the time of transplant. So we're waiting to make conclusions based on this data once we analyze it. Also, again, as I've mentioned, there was a higher incidence of CMV viremia in the obese cohort. And this is important to keep in mind because not only does CMV cause leukopenia, but valganciclovir does as well. And thus the observed leukopenia incidence in the obese cohort may be overestimated. And lastly, this was a retrospective study that did not meet power. For future direction, I think it would be really interesting to look at patients who are on a non-lymphocyte depleting agent like basiliximab for induction. This is because thymoglobulin is obviously such a potent lymphocyte depleting agent whose effects last for months. So the effects on leukopenia from thymoglobulin versus mycophenolate may be unclear in the study. And if looking at patients who are on non-lymphocyte depleting agents, the effects of mycophenolate specifically may be more pronounced. Also think it would be interesting to look at other primary outcomes, including neutropenia and GI toxicity. And lastly, for potential impact, if adequately powered studies find that a mycophenolate load is correlated with an increased risk of adverse events in certain populations, we would want to adjust our protocol to reflect that and determine who does or doesn't get a load, if anyone. Minimizing these adverse effects would improve patient morbidity and mortality, thus improving their quality of life. And also minimizing these effects would reduce costs associated with adverse event management and related hospitalizations. And if we eliminate the need for mycophenolate load in appropriate patients or even all of them, this would decrease drug utilization, thus, in retrospect, optimizing resource allocation as well. These are my references. And that concludes the end of my presentation. I'll be happy to answer any questions.
Thank you for that presentation. We do have a question in the chat. Does your protocol reduce maintenance mycophenolate total dose with reduced creatinine clearance or EGFR?
No, we do not dose reduce based on renal function. The only thing we dose reduce for is GI toxicities if patients can't tolerate the full dose.
And then one more question. Did you assess overall mycophenolate exposure during the 6-month study period, such as differences in dose reductions, interruptions, or cumulative exposure between groups?
Yeah, actually, initially when we were sort of organizing or designing the study, we thought it would be interesting to look at both leukopenia and GI toxicities, because that was actually the primary reason why they changed our protocol, because they saw a lot of our patients were getting GI toxicities. And that would have been something that we would have collected if we were to do that. But we decided, one, with the amount of time. It would be difficult to do chart review looking at the differences in like dose reductions or dose adjustments. And also just documenting that they have GI toxicities is also not like very well documented. So we wouldn't be able to say for sure that the dose reduction would be caused or is due to GI toxicities.
Perfect. Another one in the chat. Why did some patients not get the full mycophenolate load? And then follow up to that was how severe were the observed leukopenia events? And then if not weight related, what do you think is related to the leukopenia?
So to answer your first question, actually the primary reason that patients didn't receive the load was because of early discharge. Another protocol change we had recently was that originally per our protocol, we gave thymoglobulin 7.5 milligrams per kilogram over a course of 5 days, including post-op day 0. But I think it was May 2024 that we adjusted it to be 1 day less, so over 4 days, so that patients would be discharged by post-op day 3. And since the mycophenolate load is done over post-op day 1 through post-op day 5, we didn't keep them here just to finish the load. We just converted them to maintenance dose. So that was the primary reason. And then in terms of the degree of leukopenia, unfortunately, we did not collect numerically what the degree of leukopenia was, just like a binary yes or no question. But talking about it with my research mentors, like I said, in sort of the limitations, I think a big one is the fact that all of our patients were on thymoglobulin. So I really do think that the thymoglobulin sort of overshadowed the effects of mycophenolate on leukopenia in this study.
And then were there any differences in transfusion requirements?
Transfusion requirements for like blood transfusions, like for the anemia. That data we unfortunately did not correct or collect.
And then, sorry, Edith, did that answer your, because you had a similar question. Did that answer your question as well?
No, so my question was more along the lines of, so you're looking at the mycophenolate dose and you included patients who were on maintenance mycophenolate. But was there any like look into whether patients had dose reductions of their maintenance mycophenolate, whether due to like the GI side effects or leukopenia? And was there like, did that affect the rates of leukopenia at all?
Yeah, so that was hopeful. Like when we were originally designing the study, that was our hope to like capture that, particularly for the GI upset or GI toxicities, because like a lot of if they had GI toxicities, it would be more so through chart review, looking at progress notes when they follow up in clinic. But in this time frame, we didn't think it would be we would feasibly be able to collect that data for our patients. So we unfortunately did not collect the dose reductions, if there were any, and to what extent they dose reduced for this study, which would be a really interesting point for future direction for future studies.
Thank you, Jessica. Does anyone have final questions for her before we move on? Okay, perfect. Next, we will now be hearing from Michaela Morrow, which is a PGY1 pharmacy resident at Ascension St. Thomas Hospital West.
Perfect. Hi, everyone. Thank you for being here today. Like she said, my name is Michaela Morrow, and I'm a PGY1 pharmacy resident at Ascension St. Thomas Hospital West, and my research is titled Early Post-Transplant Conversion from Tacrolimus to Belatacept in Kidney Transplant Patients. I would like to disclose that neither myself nor my advisors have any relevant financial relationships to disclose. Ascension St. Thomas Hospital West is a 500+ bed tertiary care facility located in Nashville, Tennessee. We are a medium-sized transplant center that performs an average of 200 kidney transplants a year. Tacrolimus, as we all know, is a calcineurin inhibitor, which means that it prevents IL-2 production and in turn prevents the T cell activation, which stops the immune system from attacking the transplanted kidney. The dosing is adjusted based on the patient's tacrolimus trough levels, so dosing differs from person to person. It is widely used and well studied. The oral administration makes it convenient for the patient, and the cost of tacrolimus per capsule on average is a few dollars. Some things to consider with tacrolimus include it being nephrotoxic, and in order for patients to prevent rejection, they have to be adherent to taking their tacrolimus as directed, and this can be difficult for some patients. Tacrolimus is the standard of therapy for immunosuppressant in our transplant patients. Belatacept is a T cell selective co-stimulation blocker that binds to CD80, 86 on antigen-presenting cells and prevents binding to CD28, which in turn prevents the activation of T cells and the recognition of the foreign kidney by the immune system. It's used in our kidney transplant recipients in cases where the patient is having delayed or slow graft function post-transplant, or if they are experiencing intolerance, side effects, or toxicity from tacrolimus. The average wholesale price of belatacept per each 250 milligrams is about $1,200. Belatacept is dosed based off of the patient's total body weight at the time of transplant. There are many different factors that go into deciding the dose, such as time post-transplant, as well as if we were wanting to immediately discontinue the tacrolimus or slowly taper it off. Belatacept is less nephrotoxic than tacrolimus, has lower DSAs, which means lower risk of antibody-mediated rejection, and no difference in survival between belatacept and tacrolimus in the early period post-transplant. Some things to consider when using belatacept is that cellular rejection is higher in the first year versus tacrolimus, and the cost is much higher. At our center, we began converting patients to belatacept more frequently in the fall of 2023. This research project was the first at Ascension St. Thomas Hospital West to assess the use of belatacept in our patients. Of note, we also take riskier donors, so we will have a higher risk of delayed graft function and could have more patients that technically qualify for conversion. About 25% of our patients have delayed graft function after transplant. This landmark trial for belatacept was a multi-center phase 3 international study assessing belatacept versus cyclosporin in adults who received a kidney transplant. The co-primary endpoints were composite renal impairment, patient and graft survival, as well as incidence of acute rejection at 12 months. Belatacept is superior to cyclosporin in improvement in renal function and similar in effects on patient and graft survival. Belatacept was not superior in terms of rejection incidence and severity. The study is important to include since it is the landmark trial for belatacept because it's really the trial that kind of brought belatacept to the market. However, tacrolimus is more commonly used now, and it is typically considered the gold standard immunosuppressant. Since this study, other studies have assessed belatacept compared to tacrolimus and found the same outcomes. The purpose of this study is to assess the difference in renal function for patients converted from tacrolimus to belatacept within 6 months post-transplant. Like I said, our primary objective is to evaluate the impact of early post-transplant conversion from tacrolimus to belatacept on renal allograft function at 3 and 6 months post-transplant. Our secondary objectives included to evaluate the patient and their graft survival at 6 months, to assess the incidence of biopsy-proven acute rejection within the first 6 months, incidence of BK virus, CMV infection, as well as other infections, and to compare hospital length of stay and readmission rates between the two groups, as well as the overall cost of therapy. This was an IRB-approved retrospective chart review at a single center, Ascension St. Thomas Hospital West. It had 2 study arms, the tacrolimus monotherapy and conversion from tacrolimus to belatacept. The study duration was April 1st of 2023 to October 31st of 2025. Inclusion criteria was patients who received a kidney transplant between April 1st of 2023 and April 31st of 2025. If they were 18 years of age or older, they had to be EBV positive recipient serology and received tacrolimus, belatacept, or both after transplant. Patients were excluded if they had active malignancy such as PTLD, if they were pregnant or breastfeeding, incarcerated, or had incomplete documentation. Study outcomes were examined using descriptive and inferential statistics. Categorical data were analyzed using chi-square analysis. Continuous data were analyzed using the ANOVA and Kruskal-Wallis test, and statistical significance was defined as a p-value of less than 0.05. 361 patients were screened. 285 of those were excluded due to incomplete documentation, leaving 76 who were included, with 19 of those being in the belatacept group and 57 of those being in the tacrolimus group. Age between the two groups had a statistically significant difference, with the belatacept group having an older median age. The majority of patients were male, and the study was split evenly between Caucasian and African American race, with one patient in each group being of the Hispanic race and one patient being of the Asian race in the belatacept group and two in the tacrolimus group. Panel reactive antibodies were similar between both groups, and most patients were given 3 doses of thymoglobulin for induction therapy, with all patients receiving methylprednisolone. There was a statistically significant difference between the number of patients who received 2 doses of thymoglobulin, with no patients in the tacrolimus group only receiving 2 doses.
Can you guys hear me still? Sorry, my headphones just disconnected.
Yep, we can hear you.
1 second. Sorry about that. Okay, what about now?
Yeah, we can hear you.
Okay, sorry about that. Let's see. Other immunosuppressant use was similar between the two groups. CMV risk was similar between the two groups, with the majority of patients being in the intermediate risk category. Most transplants were from deceased donors. The majority of patients in both groups had slow graft function. It is important to note that there is a small percentage of patients in the belatacept group that had normal graft function after transplant, and a greater number of patients in the tacrolimus group did have normal graft function. A greater number of the belatacept patients had delayed graft function when compared to the tacrolimus group. As you can see here, these show the group's average serum creatinine over 6 months. So the serum creatinine difference between the two groups was statistically significantly better in the tacrolimus group compared to the belatacept group at 1, 3, and 6 months. And this is the group's average eGFR over 6 months. The eGFR difference between the two groups was also statistically significantly better in the tacrolimus group compared to the belatacept group at discharge, 1, 3, and 6 months. For the secondary outcomes, survival of the patient and their graft were not different between the two groups. Biopsy-proven acute rejection was higher in the belatacept group, which was statistically significant. Infections and length of stay were not different between the two groups. There was a statistically significant difference in the readmission rate between the groups, with belatacept having more readmissions, and the cost of therapy was clearly higher with belatacept. Biopsy-proven acute rejection being significantly higher with belatacept makes sense because cellular rejection is higher in the first year with belatacept versus tacrolimus. Patients who are transitioned to belatacept likely are having more complications with their course post-transplant more frequently than those who are maintained on tacrolimus, so this helps explain the hospital readmission increase. This patient population differed from those in previous studies due to the decreased renal function. This is likely due to the short follow-up period and reduced baseline renal function compared to the previous studies. For limitations, we had a limited sample size, which affects internal and external validity. We had an uneven distribution due to large number of patients in the tacrolimus group. Most other studies assess long-term outcomes, whereas our study only assess short-term outcomes. Patients were transitioned to belatacept at various time points throughout the study. Most commonly, the average was around the 2-month period. In this study of kidney transplant recipients receiving either tacrolimus or belatacept who underwent early conversion for the belatacept group, we observed a significant difference in renal allograft function in favor of tacrolimus use. Further studies are necessary to assess short-term and long-term clinical outcomes of utilizing belatacept in place of tacrolimus in patients with slow or delayed graft function. When discussing the results of this study, we also decided that additional analysis of our results through stratification of renal function is something that we want to do to see how that would affect our results. The biggest takeaway from the results of the study now is that we possibly need to reevaluate our use of belatacept in patients during the early period post-transplant. I would like to thank my project advisors and program director for all of their guidance throughout this project. I thank you for your attention. Now I will answer any questions you may have.
Thank you for your presentation. There's a question in the audience. What was the average time post-transplant patients were converted to belatacept? And then the follow-up to that was, and was there any analysis of the severity of the BPLAR episodes between groups?
The average time post-transplant was about 2 months. So ideally, if we were also to redo the study, we would start at the time that they're transitioned to belatacept to assess the renal function at that point. That would be something that would be interesting to see. And we did not analyze the severity. We just kind of had a yes/no question on if they had biopsy-proven acute rejection as a collection data point.
And the next question is also from the audience. How many of your belatacept patients received tacrolimus and were converted? Follow-up to that was, in those patients, what was the conversion protocol used, and did you see an increased rejection risk during the conversion or more while on maintenance therapy?
So all of our patients but 2 received tacrolimus before they got belatacept. So there were only 2 de novo belatacept patients. And then we have updated our conversion protocol this year, so I'm not exactly sure what they were doing previously. I would have to double check with the team on that. It was kind of, we've created it to be more structured this year, so it was a little bit kind of provider specific previously. And we did see increased rejection risk with those patients.
And then what was the definition of normal versus slow renal function?
Yeah, so we didn't really have a definition of normal, but for slow graft function, it was provider specific once again. So we just looked, and if the provider defined the renal function as slow, and then delayed graft function obviously is the need for dialysis within 7 days post-transplant. But we didn't really have one that was categorized as normal.
And then another question was, based on your findings, do you think these results should influence practice at your institution regarding the frequency of conversion from tacrolimus to belatacept or the selection of appropriate candidates for conversion?
Yeah, I don't know if necessarily now it would change how we do things. I think maybe the stratification of the renal function would really help. Maybe getting some biostats on that would be very helpful. I don't know if for sure now we can say like it's not helpful in these patients because we do see 1 year after they've been on belatacept, we do see really good effects on their renal function. So just kind of taking a hold on like maybe converting so many patients until we really figure out like the best patients to use it in, I think is what we took away from this study.
Thank you, Michaela. Does anybody have any final questions for Michaela today? Sound like it, so okay, that sounds good. I'm gonna give it back to Crystal to close us out.
Well, thank you everybody for attending today's webinar, and on behalf of the ACCP Transplant PRN as well as AST Transplant COP, thank you for joining our second annual resident research webinar, and a special thank you to our residents for presenting their research today. Just as a reminder, all attendees will receive an email after this webinar with instructions for obtaining CE. We do have one more webinar scheduled for next Thursday, so we look forward to seeing you next week. But besides that, have a good rest of your day, everybody.